I believe malaria eradication is possible in Africa with the right tools, with sufficient political commitment. I think that is really key. For us in Africa, we really have to own that vision. Countries really have to own it. And there has to be that political will and commitment that, yes, we want to see to this. We will also need to have that political will and commitment will need to translate into resources and investing in local resources for malaria. And then the investment must be consistent. It doesn't make sense to do it for 2 years, 3 years, and then you stop.
Hello and welcome to another episode of the Africa Within podcast. I'm your host, Nondobego Mlambo. Thanks for joining us at Africa Within, where we hold critical conversations on health, peace and climate change across the continent and shine a light on the solutions emerging from within. Today is Malaria Day, so we turn our focus on one of the most persistent public health challenges facing Africa, malaria. Despite decades of progress, malaria continues to claim hundreds of thousands of lives each year, most of them in sub-Saharan Africa. We are honored today to be joined by a public health expert, Dr. Olusola Oresanya, the Country Technical Coordinator for Nigeria at Malaria Consortium. Dr. Oresanya brings with her a wealth of experience and insight into Nigeria's malaria control and elimination strategies, community health interventions, and the broader goal of ending malaria and reaching zero malaria in Africa. She has over 20 years post-qualification experience as a medical doctor in program design, policy formulation, planning, implementation, surveillance, monitoring, and evaluation of malaria control strategies. Thank you so much, Dr. Oresanya, for joining me today. Could you please just talk about yourself, your role at Malaria Consortium, and your experience with malaria-related work?
Thank you very much for having me. So my name is Olusola Oresanya, and I serve as the Senior Country Technical Coordinator for the Nigerian Country Office of Malaria Consortium. And I have the privilege of leading the technical team in that office, providing technical oversight for all the projects and programs within Malaria Consortium's portfolio in Nigeria. A public health specialist with over 20 years experience in malaria program design, implementation, monitoring and evaluation, and research. So I'll just leave it there.
Okay. What was your inspiration? Why did you decide to start doing this kind of work, specifically to fight the malaria fight?
Wow. So that was a very personal decision that I took. I actually wanted to study pediatrics. I wanted to specialize in, treating children. But I had an encounter or an experience while I was doing my house job at a teaching hospital. I was on call that night, and they had brought a child that had severe malaria, was actually at the point of death, was pale, had lost so much, was anemic and all that. And, as a young doctor then, I knew what to do. And so I had quickly collected blood to do all the things that I needed to do, to transfuse the child with blood, give oxygen, and then give the treatment for malaria. But unfortunately, the system, did not provide all the enabling environment that I needed. Blood was not available in the hospital. At that night, there was no oxygen. I had to be amble back in. At the end of the day, I lost that child. The baby died, and that night, something just turned in me, because I felt like I could do much more. I could, have an impact at a higher level, policy level, because somebody in that hospital was supposed to provide oxygen, and somebody was supposed to ensure that that was available, but that wasn't done. Somebody needed to check that things were in place, that the right environment was there, supplies were available, but that wasn't done. So I felt like, no, I'm not going to do this. I would go into public health where
Yeah.
I can influence policy, influence practice, and be able
Yeah.
to impact, at a on a larger scale than individual level. So that's how I found myself in public health. And the
Yeah.
first thing I assumed in my Ministry of Health then, I was posted to malaria program, and I just fell in love with it, and I've been there ever since.
Okay. Um, what is Malaria Consortium's overarching mission in Africa, and how does it contribute to global malaria eradication efforts?
So Malaria Consortium is one of the world's leading non-profit organizations, and we specialize in the prevention, control, and treatment of malaria and other communicable diseases. Actually, we don't do just malaria,
Yeah.
and our mission is to save lives and improve health in communities that are at risk of malaria, especially in Africa and in Asia. And we do this through evidence based programs that combat those targeted diseases and then also promote universal health coverage.
Okay. Um, how does Malaria Consortium collaborate with communities to promote the use of insecticides, treated nets, and indoor residual spraying?
Yeah, so indoor residual spraying and insecticide treated nets are high impact interventions for malaria prevention. The insecticide treated nets are the main vector control intervention that are deployed across communities in Africa. And then in 2023, although like 73% of households in sub-Saharan Africa had at least one net,
Yeah.
only 45% of households reported owning at least one net for every two people. Yeah. And less than 60% of the vulnerable populations, those are the pregnant women and the children under the age of 5, slept under the net the night before. So you see that there are indications of gaps in ownership, in access, and in use of bed nets.
Yeah.
Consortium supports resource mobilization, and we advocate for increased supply of ITNs in those areas that are needing them. And we also, advocate for investments in implementation research and the use of behavioral insights to understand why is it that people don't use bed nets? Why would you get a net and you wouldn't sleep under it? What are those barriers to people really using the nets? And how can we, remove those barriers so that people can use those barriers? So we conduct research, implementation research to understand, those behaviors that are behind the use or the non-use of
Yeah.
bed. And we also support in countries like Ethiopia. We work with existing infrastructure, the health infrastructure like the Health Development Army. That's a cadre of local community health workers. We use them, we support them to sensitize households on the benefit of indoor residual spraying and also to improve acceptance of that
Yeah.
intervention.
Okay. So some of the prevention measures include the two available vaccines. How have you seen those two available vaccines impacting the lives of people affected with malaria, especially maybe in your country of Nigeria and across the continent?
Yeah, I think the malaria vaccine is a groundbreaking development in the fight against malaria. Those two vaccines, when they were introduced, the first one in RTSS was introduced in 2021, and then 2 years later, R21 came into being. But the launch, the actual implementation, didn't start until January 2024.
Yeah.
And since then, I mean, it's almost a year and a half now, and over 10 million doses of malaria vaccines have been delivered to more than 17 endemic countries through
Yeah.
the Gavi malaria program. And this is about, we're talking about protecting about 5 million children, with malaria vaccine. I think that is really huge. Of course, there's still a lot of, miles for us to cover, but I think that's some progress. And most countries adopted the malaria vaccine using a phased approach to the introduction. Cameroon was the first country to launch it as part of
Mm.
their um, routine immunization program. And they did that in 42 districts with, a plan to scale up gradually.
Yeah.
But, about a year after they launched, the early results that came out from their API program showed that in those areas where they deployed malaria vaccine, they had 17% more reduction in all-cause hospital consultations for children under 5, meaning that less children were getting sick, you
Yeah.
know, in those areas where malaria vaccine was given compared to the areas that they had not introduced the malaria vaccine. And
Mm.
about 60% of the malaria vaccinating districts recorded a drop in all cause under 5 deaths, meaning that fewer children were dying, from all causes. And then even the deaths that are linked also recorded, a lot of reduction in those. So we see that the gains are already evident. However, we are likely to have greater impact when the deployment of the malaria vaccine is combined with other malaria interventions. It should not be seen as a magic bullet because it's not actually. It has to be used in combination with other interventions like ITNs, like IRS, like
Mm.
perennial malaria chemo prevention or the seasonal malaria chemo prevention. And then effective case management also still has to be in place because some children will still fall sick. So there must be drugs to treat them when they
Yeah.
fall sick. And we also ensure that we use optimal delivery strategies for the malaria vaccine so that we can reach more children who are
Yeah.
eligible.
Okay. We're in the continent that faces a lot of conflict, and a lot of people get displaced. What challenges do people in places like that, conflict affected areas, face when they are accessing malaria treatments?
Yeah, so evidence shows that people who live in rural areas are more affected by malaria than
Mm.
those who live in urban areas.
Yes.
1 in 8 people lives more than an hour from their local health center, for instance,
Yeah.
and 1 in 6 is more than 2 hours from a hospital. So you can imagine if anything happens,
Mm.
for instance, in the middle of the night, because malaria doesn't announce when it's going to strike children.
Yeah.
And the hospital is 2 hours away in the middle of the night. So for
Yeah.
those living in those rural areas, distances are often, you know, a huge barrier, distance to the nearest health center.
Mm.
And there can be barriers. And looking at the barriers, maybe I would categorize them into 3 areas. One, you can have delay in recognizing that this child is ill
Yeah.
and this child could have malaria.
Yeah.
Again, most of those women who live in the rural areas are uneducated. They do not have the requisite knowledge of the symptoms and the signs of malaria. Some of
Yeah.
them don't know what to do when the child has fever, and they do all the
Mm.
things that they just know to do. They tap it sponge, they pour cold water, they do all that. and some don't even know where to seek help. So that
Mm.
delay, and because when a child has malaria, you have to intervene within 24 hours,
Mm.
especially a child that is under the age of 5, because malaria can progress very rapidly into severe malaria, which can claim the life of that child if care is not accessed as
Mm.
quickly as possible. So if there is so usually those barriers will cause that first level delay, because the mother doesn't know what to do, doesn't even know that the child has malaria, maybe thinking this is something else. And then the second level is the delay in reaching an appropriate source of care.
Mm.
We talked about distance the other time, that if a child has already slipped into severe malaria, for instance, is already having cerebral malaria, is convulsing, that child needs help immediately. Now, if there is a delay in getting to the health center because of the distance, because there are, no good road network, transportation is costly, the mother cannot afford it, and or sometimes, like you talked about, conflict. Some villages are
Mm.
completely cut off because of the conflict. Some places are inaccessible, and sometimes
Mm.
disasters also cause, you know, access barriers, and you can't access a facility because there's flood on that path, and so there's.
Mm.
So those are the kinds of things that cause delay. The third level of delay is assuming that that mother eventually gets to the health facility against all odds. And then the health worker say, "Oh, I'm so sorry. We ran out of drugs. There are no supplies in the health facility. The health worker is unable to help the child, even after crossing all those hurdles to get to the health. That is the third level of um, of delay that constitutes a barrier, to accessing care for people who live in remote areas where there's conflict, there are natural disasters that have cut them off from where supplies are.
Yeah. What would a fully funded, data driven, vaccine supported strategy for malaria eradication look like?
I would say that that would be a dream come true, to have all the resources that you need, everything in place. It would really be a dream come true for malaria
Yeah.
control efforts. Yeah. So, and as countries approach elimination, data generation, processing, and the use of that data for response will need to be increasingly in real time and in more localized target areas, so that we can maintain whatever progress that it is that we have achieved over time. So, a fully funded, data driven, vaccine supported strategy for malaria eradication will really help to accelerate the fight against malaria. I think it will do that, one, by first of all enabling malaria affected countries to use high quality data to feed into their subnational tailoring. Subnational tailoring, malaria stratification is what WHO recommends for countries, because at the moment, um, malaria control is not expected to, you're not expected to deploy everything everywhere. It has to be targeted and tailored towards what is the malaria burden, or um, the malaria status, the geography in the country. So malaria stratification helps the country to identify, the mix of interventions that are best fit, for specific regions in the country. Because in most countries, you would have areas that are high in malaria burden, some are low in malaria burden. Malaria cases are high in some areas. So in those areas, you don't have to deploy the same intervention everywhere. So you need data to be able to stratify and now target, the areas with specific interventions that are needed to achieve impact and maximize impact in those areas. So where resources are available, then countries will be able to do this. They will be able to use high quality data to feed into their own subnational tailoring approach so that they can inform the optimal mix of intervention that they should deploy. Secondly, being fully funded will mean that you can actually deploy all the mix of intervention that you have identified with your malaria stratification. Because what usually happens at the moment is that once countries do go through that process of malaria stratification, they then find out that, oh, we don't have enough money to do all this, even though our strategic plan you know, says that if we do this and do that, we would achieve so much impact. But then the country will have to look at the resources available and then try to prioritize out of all this mix of interventions, which one can we do within the available budget that we have?
Yeah.
You understand? Then they limit some, they drop some, retain some. But if it is fully funded, like you said, then there will be no need to drop any. So which means you can deploy everything that data has shown you you need to deploy. And that would be, like I said, a dream come true. It will enable countries to actually be able to maximize impact and be able to reach the end game much quicker, much faster.
Yeah. When we spoke about the nets, you said something about some would have nets, but it's not clear why they would have a net and not sleep under a net. And you said you then at Malaria Consortium do research on on such instances. What kind of research has the organization or is currently undertaking or has undertaken in the past to develop better tools or strategies for malaria control?
So our research explores barriers to accessing quality healthcare,
Okay.
especially in low and middle income countries in Africa and Asia. We also use unique cultural and social factors that affect health outcomes in specific population. We study those unique and sociocultural factors that
Okay.
can affect the outcomes of health. So we work with many different stakeholders to use evidence to, tailor interventions and devise strategies that address the need, of their communities. And this includes, evidence to inform decision making on prioritizing resources. I talked about the fact that most times when countries plan or prepare their strategic plan, resources are never enough, to
Yeah.
do everything that they want to do. So Malaria Consortium support countries to, prioritize their resources and ensure that they are deployed as efficiently and effectively as possible so that whatever little resource you have, we support and provide evidence on how you can deploy them efficiently and effectively so that you can optimize impact. An example is a research project that is currently ongoing in Nigeria on on perennial malaria chemo prevention. We are carrying out that intervention or that research to gather evidence that will support Nigeria in taking a policy decision whether to on how to scale up perennial malaria chemo prevention. That is an impactful intervention that is currently not a policy recommendation in Nigeria, and which we believe can be added as a tool, to the malaria toolkit in the country, because you would have to. It's a multi-pronged approach, to win the war against malaria, and since that is not yet a policy recommendation, Malaria Consortium is supporting the country to gather evidence on how do we deploy this intervention in such a way that we are able to achieve high coverage and also able to, you know, contribute to the reduction of malaria morbidity and mortality in children under the age of 5. So those are examples of the way we support country to develop better strategies for malaria control across all the countries that we support.
Yeah. How is data-driven research shaping malaria policy and implementation in the African continent or in African countries?
Yeah, so I mentioned earlier that um, one of the one of the strategies recommended by WHO for countries is malaria stratification. And in the high borderline impact countries those are the countries that are contributing the largest. There are just about 11 countries that are contributing, to the huge burden of malaria globally. And so the high burden, high impact initiative of the WHO recommends that those countries use local data to inform malaria, targeting malaria, or tailoring of interventions that are deployed in the country. So using subnational data, integrated surveillance technology and genomic data to tailor intervention effectively are some of the approaches that some countries have begun to adopt, that are helping them to shape policy and implementation across Africa. Integrated surveillance is another one. Comprehensive surveillance systems are, increasingly integrating useful data from different sources, epidemiological data, genomic data. Some are even gathering climatic data to inform trends in malaria risk so that you can even predict, and create early warning systems when there's an outbreak that is imminent. You know, AI, artificial intelligence, also offers the opportunity to aid, decision making using advanced and predictive analytics. And, you know, those are opportunities that some countries are, already beginning to take advantage of. Targeted intervention, once you have data, you can then use that data to target your intervention to you know, where an outbreak has happened because you have data coming in, alerting you. And so you target that place with the appropriate intervention to quickly intervene. So it's helping also to, not just to intervene, but to intervene on time, knowing that malaria is a disease that, progress very rapidly, especially in children and pregnant women, if intervention is not quick and adequate. Data-driven approaches also help with community engagement, being able to, you know, we collect data from the community, feeding back to that community also. When you collect data from them, feeding back to them to say, okay, this is what data from this community is saying. You have issues in this area and that area, and then working with that community to address the issues that have been identified. Community engagement, community involvement, are some of the approaches that, countries are deploying, you know, to improve malaria outcomes across these areas.
Okay, we know that three countries that have been certified malaria-free by the WHO: Algeria, Cape Verde, and Mauritius. What lessons can we learn from their approaches?
Okay, so these are countries that have been certified malaria free. And, one of the things that is very important as countries move from control to elimination phase, one of the things that is critical is malaria surveillance. It will be very important, and the WHO has, pulled it out as a cross-cutting or supportive intervention to become an intervention on its own, because it's that important, especially as countries move from control to elimination. You would need to be able to track every case. You will need to be able to treat every case. In fact, once a case is detected, you have to round up everyone in that area and treat everyone so that you are able to nip that in the bud. So real-time tracking of every case of malaria, which over time becomes really expensive, you know. But the challenge, with that is that in many African countries that have, moved into that phase, and because it moved into that phase, or some districts, for instance, I'll talk about Nigeria. In Nigeria, there are some states in the country that are actually in pre-elimination, even though overall malaria prevalence in the country is 22%. But there are some states in the country that have less than 5% malaria prevalence. At a point, there was a particular state that went as low as 1% at some point. But the response was that, oh, these people are doing well. They don't need bed nets anymore. We take the bed nets to the areas
Wow.
that still have high prevalence, and then support, and all sorts of stuff for malaria in that area ceased. And do you know what happened? The cases started going up again. You know,
Yes.
we
Yeah.
didn't. I mean, the intervention was. I mean, the response was wrong. So in such areas, what you need is to now deploy, you know, malaria elimination strategy, strengthen surveillance, put in place surveillance so that those cases, and then the bordering states, that still have high malaria, you also have to do something about them. Those are the things that these countries did. They didn't just push out malaria or reduce it or push it out in their country. They looked out for countries that were bordering them, and also institute cross-border interventions against malaria, so that if in your country you have eliminated malaria and the other country, and there are travels, mixing of people come in and out, and you don't have a strategy to forestall those transported cases into the country that then become established again, that would be an issue. So those were some of the things that were deployed in these countries that helped them to eliminate. And there are other countries also that may not have eliminated malaria, but they are on the path towards elimination because they're doing very well. Rwanda, particularly, is one of the African countries that is on track to meet
Yeah.
its 2030 malaria reduction targets, and doing, excellently well in combating it. They are investing in community, engagement, community mobilization. That's one of the big strategies that they used to drive down the cases. They took case management of malaria very close to the households. We talked about people being able to access care, those who are living in remote areas, rural areas, access. They took the care. So you can walk to your community health workers' house in the same community to go and access care for your child. And when they deployed that, they saw a massive reduction in the cases. So those cases don't even have to go to the hospitals. So it's reducing burden on the hospital. The health workers are able to treat,
Yeah.
more severe cases. Then you don't have to take every case to the hospital. So those are some of the strategies that have helped, and lessons that we really can learn from other countries, from countries that are doing well, and those countries that have, eradicated or eliminated malaria from within their borders.
Yeah. Having been in this field for so many years, what are some of the barriers that are still remaining in the way of achieving zero malaria?
The barriers are daunting. One of the big barrier or threat to malaria elimination right now is this resistance to the current tools. Um, these resistance are, insecticide resistance
Yeah.
to the insecticides that are used in the bed nets. And, many countries are now, recording resistance to the insecticides that we now require, deploying other types of bed nets depending on the kind of resistance that is happening. It requires you, deploying different types or other types of bed nets. And those other types are more expensive. You can imagine in a place where you have limited resources, and then you now have to buy something that is more expensive, and you have to deploy that across the entire country, or an entire region. It means
Yeah.
that there would be an opportunity cost because you won't be able to do some other things if you have a limited pot of resources.
Yeah.
So insecticide resistance is one big threat. Then drug resistance is also a big threat. You know, that's one of the big threats. It's been recorded in Asia. Artemisinin resistance and artemisinin based combination treatment is the only drug that we have right now that is helping, is the main one that we are using to fight malaria right now. Imagine if the parasites become resistant to that. What are we going to do? So that's another big threat. And the scary thing is that it's already been documented. This resistance is entering into Africa from Asia. Some African countries are already beginning to document resistance to artemisinin, and even the the drug that it is combined with. Some are already recording, resistance to them. And so these are big threats. It will require, us deploying more resources, looking for more tools, investing in research and innovation, you know, like the malaria vaccine, a lot of research went into that before it became a reality. And today we can say that's a reality because some people took the initiative to start, investing in that.
Yeah.
So it will require us using the current tool that we have more effectively, combining them, using them well, using them more effectively. It will also require us innovating because the malaria parasites, they are always evolving. Also need to evolve in the way we are combating it. We need to rethink the way we do our interventions. We need to rethink the way we deploy, our interventions and how we even allocate resources, especially nowadays that resources are becoming more and more scarce, in the health domain. So those are some of the challenges um, we need to combat.
You already spoke about the challenges, but are you hopeful that we will eradicate malaria at some point in Africa? And what needs to really happen for that to happen?
Yeah, I believe malaria eradication is possible in Africa with the right tools, with sufficient political commitment. I think that is really key. For us in Africa, we really have to own that that vision. Countries really have to own it.
Yeah.
And there has to be that political will and commitment that yes, we want to see to this. We will also need to have that political will and commitment will need to translate into resources and investing in local resources for malaria. And then the investment must be consistent. It doesn't make sense to do it for 2 years, 3 years, and then you stop. There's a tendency that there would be a rebound. I gave an example earlier on. Once you say, oh, we are winning the battle here, let's leave this one and go to another place, there can be a resurgence. So that fight has to be consistent until we get to the end across everywhere. And resilience also will be important. When there are issues, we refuse to give up. We consistently invest. we are innovating, we are committing ourselves and investing in research to developing new tools. So I believe that where there is a will, there is always a way.
All right. Thank you so much. We've come to the end of our interview. Thank you so much for your time. And thank you for all that you do in the public health space in Africa for Africans.
Thank you very much for having me.
Thank you. Thank you so much for joining us today on the Africa Within podcast. And we say a huge thank you to Dr. Olusola Oresanya for sharing her expertise and shedding light on what it truly takes to eliminate malaria across Africa. From community level interventions to national policies and global partnerships, it's clear that progress is possible, but only with commitment, coordination, and continued innovation. As we reflect on this conversation, let us remember that malaria is preventable and treatable, and with collective action, we can make elimination a reality. If you found today's episode insightful, don't forget to subscribe, share, and follow us for more powerful conversations that center Africa's health, peace, and environmental future. Until next time, keep the dialogue going and keep Africa within.